All right. Good afternoon, everybody. Today it's just going to be me. Um, we are going to talk about antimicrobial IV to PO conversion. So we're going to be talking about antibiotics, switching them from IV to PO. So antibiotics, antivirals, antifungals. Is it possible to uh, give them PO just as well as IV? So that's something we're going to talk about. If you have any questions, please post it in the chat, and I'll make sure that I address all of your questions. So I'm not sure if you've heard about Brad Spellberg. Brad Spellberg is an infectious disease doctor that has a website that talks about dogma and myths in infectious diseases. I think he's at USC. I think he's in California, and uh, I really like him because he gives these talks about things that everyone thinks are true, but may not necessarily be true. And that's true in all of medicine and all areas. There are things that, people do things like they've been done in the past, but it's important to, you know, look at studies and see if it needs to be done that way, or if, we can kind of adapt and learn from the new studies that are done. So, um, here's one of his articles. Can the future of ID escape the inertial dogma of its past? The exemplars of shorter is better and oral is the new IV. So on his website, I have a lot of screenshots from his website that we can talk about. But again, I really like it because it breaks a lot of the conventions and a lot of the things that we think need to be done in a certain way. So this one's the two historical practices that have been overturned recently by numerous prospective studies, the traditional durations of antimicrobial therapy. So, his on his website, he talks about shorter is better when it comes to durations of antibiotics. And so in the past, people they would say that you need a certain duration. And the more studies that are done, the shorter the durations become. So in the past, they would say you need 2 weeks of antibiotics for pneumonia, for example. And then, it comes down from 14 days to 10 days to now it's 5 days of antibiotics as far as durations of treatment for pneumonias. And there are even, very short durations there where they look at 3 days of antibiotics for patients, even if the patient's, severely sick in the ICU. They have super short durations of 3 days that actually, the patients even do okay with 3 days. So that's one of the things is durations. When it comes to antimicrobial resistance and the development of resistance, people they used to say, "Oh, you need to give um, the whole course of antibiotics," and they would blame the patients that didn't finish the antibiotics and say, "If you don't finish your antibiotics, that's where we get the resistant organisms from." And so they would blame the patient and say it's the patient's fault they didn't finish their antibiotics, and that actually has changed. And um, they used to say it was from not finishing the antibiotics. Now they say it's from taking antibiotics too long. So if you take antibiotics longer than needed, then you're developing resistance. So it actually completely changed. So we talked about a little bit about traditional durations of antimicrobial therapy as one of the dogmas, and we'll get more talk more about that. And then the next one is the need for IV only therapy for specific infections. So there sometimes people think you need IV only for specific things, which we'll talk about, but they'll say, "Oh, you need IV and pills won't work." And that's actually not true for a good number of infections. So pills work very well. And there's nothing magical about giving IV antibiotics. So people will think that IV only will work when really the most important thing is the concentration of antibiotics at the site of the infection, right? So if you're giving an antibiotic by pill, or IV or however, how much of that antibiotic, what is the concentration where you need it? Where you need it to, the concentration to be high enough to kill the bacteria that's causing the infection. So if you're taking a pill and you can get good concentrations where, where you need it, then that's the most important thing. Now, um, how well, and along with that is blood flow. So how well or how much blood flow are you having to the area where you have the infection is a really big deal. So, when it comes to um, location of infections, we get a lot of foot infections, and that's because the blood flow is poor in that area. So if you have someone that has been like a 200 smoke pack year history, like they have a million pack year history, then their blood flow is not going to be as good because of the peripheral vascular disease. Um, so diabetic patients, smokers, that's where you get into trouble with the blood flow to the feet, and that's why we get most of the infections there. Places that are really well vascularized generally don't see infections there as much, right? And that's because your immune system can get there and you know try and take care of the problem. But also, if the blood supply there is poor, sometimes even if you're giving IV antibiotics and you're giving a lot of antibiotics, if the blood flow can't get there, then the antibiotics can't get there. So in those patients, I've seen patients where they have osteomyelitis in their foot, or they have a chronic infection in their foot, and they can't get it better even with no matter what antibiotics we give. Uh, and they'll have, a stent placed, an arterial stent, improve the blood flow, and then very quickly the infection gets under control. So these dogmas are based on uncontrolled case series from over 50 years ago sometimes, and the opinions of the experts at the time. But there are a lot of studies showing that PO antibiotics actually work very well. And sometimes, with stewardship, sometimes we'll call someone and discuss changing from IV to pills, and sometimes they'll say, "Oh, I've been practicing for 30 years, and this is how I've always done it." And that's great, but it's important to also think about, uh, what's being shown now in the studies, and kind of adapting and evolving, how we treat uh, our patients. So this is a summary of randomized controlled trials of I'll say PO versus IV only therapy. So this is looking at the number of randomized controlled trials demonstrating that IV is better than PO. Let me I'll get a pointer here. So this is number of randomized controlled trials demonstrating that IV is better, superior to PO. 0 for osteomyelitis, bacteremia, endocarditis. Number of randomized controlled trials demonstrating that PO antibiotics, oral antibiotics, are equal to or better than IV. And osteomyelitis, there were 9, bacteremias 10, endocarditis 3. So this is looking at pills versus IV only. So sometimes some of the treatments will be IV for a short course, for IV antibiotics for a number of days, when a person is first hospitalized, and then changing to pills for the duration of the course. And that is kind of how I think about, oh, well, it makes sense for me for how I think about infections, because when the patient first comes in, if they're very sick or they have a bad infection, the bacterial load, so the number of antibiotics, will be extremely high. And then if you give antibiotics like IV antibiotics for, or really any antibiotics for a couple days, the bacterial load decreases, and then really then you're just kind of mopping up the bacteria that's there. But you want to get the bacterial load way down, and then you kind of give a maintenance therapy for a while. So IV at the start, and then pills to continue. And that's been done with osteomyelitis, bacteremias, endocarditis. Shorter is better. So this was from one of the studies, or this is from the review, but it's also on his website. And I'll show you a screenshot of his website in a bit here. But they look at shorter is better, randomized controlled trials. So now, why does it shorter is better and not shorter is equal, right? So it's shorter is better because if you're able to give pill antibiotics and let's say the patient gets gets better and improves just as well as they would on IV. Well, the pill is better because you're not dealing with the added complications and problems of having IVs. Uh, that's including having a PICC line, getting poked, um, but having a midline or a PICC line causes problems also, right? So you can get thrombophlebitis, you can get a phlebitis, you can get infections from the PICC line, you can get complications from the PICC line, and just uncomfortable having a PICC and all the issues with PICC lines. So that's why it's shorter is better and not shorter is equal. Now, they have community-acquired pneumonia, and they'll look at short durations, 3 to 5 days, versus long durations, 5 to 14 days, and the result is equal. And there were 14 randomized controlled trials showing this. So, and this is the ultra-short course that I was mentioning earlier, the 3 days, and this is even for patients that are very sick in the ICU, but ultra-short course of 3 days of antibiotics was the same as 14 days, or 5 to 14 days in the studies. So atypical community-acquired pneumonia, short versus long, the number of trials, and then you come down, and it has a lot, right? So ventilator-associated pneumonia. So these are things that people would say, oh, for ventilator-associated, you would need to be very aggressive, but I wouldn't think of pills. It's another way of doing it. Um, uh, so it's kind of trying to change the mindset of uh, if it works, then it's another option. Complicated urinary tract infections, complicated intra-abdominal infections, cellulitis, and you can just see the list here that there are a lot of studies. And when it comes to osteomyelitis, um, short versus longer, this is just looking at the days of treatment. It's not looking at PO versus IV. Now, when it comes to giving antibiotics by pills versus IV, the thing that's important here is that we'll discuss is bioavailability. So bioavailability is the fraction, so it's the percent of a drug that reaches the systemic circulation. So if you take a pill, what percentage of that pill or how much of that pill reaches the bloodstream, right? So if you take a pill and you know, if 100% of it gets to the bloodstream, then there would really be no benefit of giving it IV versus giving it by pill. So, for example, levofloxacin is 100% bioavailable. So there's really no advantage of giving IV levofloxacin if you can just give them a pill, right? So if it were me and I'm getting levofloxacin, I would rather just take a pill than have, a PICC line and an IV when 100% of that pill is going to make it to the bloodstream. And you can also kind of think about it when you order levofloxacin. If you order it IV or if you order it PO, it's going to be the same amount, right? If you're going to order 750 milligrams once daily of levofloxacin, you can give 750 milligrams by pill or by IV. So you don't even change the amount you're giving because 100% of it's going to get to the bloodstream. So when you're looking at antibiotics, here this is antimicrobials with high or very high oral bioavailability. So things like linezolid, 100%, levofloxacin, 100%. Now, cephalexin is Keflex. It's somewhat unique when it comes to beta-lactams because beta-lactams in general are not as bioavailable as some of the other antibiotics, but cephalexin is kind of an exception, and it's very bioavailable. So you can give it by pill and be confident that it's getting to the site in high levels. Clindamycin, very bioavailable. Fluconazole for fungal infections, also very good. So if a person is eating or taking pills in the hospital, then you can switch them to pills and they don't need to be on IV. And there's a big benefit to the patient for that, and also for the staff. So the pharmacist doesn't need to mix it up, send it to the room, or have someone go get it, bring it to the room, have someone start an IV, have someone hang it, have someone, monitor that they're doing okay, when really you can just give them a pill. So it actually saves a lot of money and time. And that's something that, when it comes to showing benefits of stewardship, there's going to be sometimes there are cost savings that are kind of across different departments. So, the cost saving in the pharmacy and nursing and perhaps PICC line placement, or if a patient goes home with a PICC on vancomycin, people will say, "Oh, the vancomycin is very cheap," but the vancomycin is cheap, but then you have to have people spend time mixing it up, getting it ready, taking it to the patient's house, giving it. Then the patient has to have labs. So they have to, have their labs drawn if someone goes out to the house or they go in. Then you have to monitor those labs. Then someone has to interpret those labs. And, there's a lot of cost that goes into that, and time. And that's not always captured in like the benefits of stewardship and things like this. Um, and then you can come down here and see, Bactrim gets in very well, doxycycline gets in very well. And sometimes it depends, if it's taken with food or without food. Itraconazole is another one that it depends if it's taken with food or without food, or if it's in an acidic environment, it might be absorbed better. So itraconazole is absorbed better with in an acidic environment. So sometimes we'll tell patients, if we monitor their levels and they don't have good levels, we might say to them, um, you know, recommend taking it with a Diet Coke or with orange juice. Uh, and then it's in an acidic environment and it gets absorbed better. So here's here's another. This is Kuna. This is kind of a famous person in the ID world. Um, and here was something on antimicrobial stewardship program perspective, IV to PO switch therapy. Um, now, um, so this is looking at bioavailability of different things here. So at the top, it has excellent, greater than 90%, and then good and poor. So you can see that some of them, if it has very good bioavailability, and then we have antibiotics here, we have antifungals like voriconazole, isavuconazole. Um, if it gets in very well, um, then it may be a really good option. And then also, where is the infection? What organ system? So some things get in, uh, antibiotics get in easier in some organ systems versus others. So if it's a CNS infection and needs to cross the blood-brain barrier, you might want to push up the dose and make sure that you're giving something with very high bioavailability. Um, and versus if it's in a skin and soft tissue infection, where you're going to get higher levels of the skin and soft tissue versus getting into the CNS. And there's a question: what are your thoughts on Vantin for gram-negative rod bacteremia? We did a study and found that both Keflex and Vantin have great bioavailability. Yes, so Vantin is cefpodoxime. So cefpodoxime has very good bioavailability. So here on the, let's see, is cefpodoxime on here? Yes, so cefpodoxime, here it says 60 to 90% bioavailability. So if a patient is getting antibiotics in the hospital, like ceftriaxone, then if you have a susceptibility report for the organism and it says something like ceftriaxone or third generation cephalosporin would work well. If you're getting ceftriaxone in the hospital, but you want to send them home, so say if they have gram-negative rod bacteremia, it's fine if the patient's doing well. It's fine to switch them from IV to PO. And then as far as choices of antibiotics, if you're going to choose a third generation cephalosporin, and they're in ceftriaxone in the hospital, third generation cephalosporin, you want to send them home with something by pills. Then generally the options, we will look at cefpodoxime versus ceftonir. And ceftonir is down here, and it's poor. It's less than 60% bioavailable. Um, so if possible, we'll send them home with cefpodoxime, because it's just like in the comment, just like you said, cefpodoxime has very good bioavailability. Even better if you take it with food. Cefpodoxime can sometimes be a little bit more expensive, so um, it can be too much, and insurance companies won't pay for it because they'll want to give something cheaper like ceftonir. But if you can give cefpodoxime when you send them home, that would be a great option. And so that's what I do when I see patients with gram-negative rod bacteremia, like E. coli or Klebsiella. If they have a bacteremia um, and they're improving, then I'm fine sending them home on PO. And then you also mentioned Keflex. Yes, if Keflex works, if it's susceptible to Keflex, then I will give Keflex or cefpodoxime uh, is what I would prefer. And then the other option would be ceftonir. Cefpodoxime are going to be twice a day, whereas Keflex, uh, um, Cephalexin, I usually give it 3 times a day. Now, advantages of PO antibiotics. So IV antibiotics are overused in hospitals. Many infections can be managed with PO. It avoids problems with IV administration. It's less expensive. And so really, through stewardship, if a patient is on an IV antibiotic in the hospital and it's possible to switch them to PO, that is one of the low-hanging fruit. That's one of the low-hanging fruit. So that is something that we will, um, uh, you can easily switch people, um, and that's a recommendation that we'll make. Now, sometimes if a patient is, you know, if we make that recommendation, sometimes it's not taken, and sometimes the reason is because, the patient may have vomited that morning, or the patient may not be able to swallow pills very well, or something that we can't see from reviewing the chart, which is totally understandable. Um, And again, the benefit of oral route, so it's prevention of line-related infections and thrombophlebitis, lower drug cost, and a lot of these hidden drug costs, and such as monitoring. And here we have advantages um, of oral antibiotic therapy. So uh, now, rapid gastrointestinal absorption. So if a patient has poor absorption, so if they've had a GI surgery, or if they've had bariatric surgery, or some kind of um, uh, intestine that's been removed, then the question is, how well are they absorbing? If there's any question of, can they absorb it or not? That's something you want to ask when you're giving the antibiotics. But it also decreases the length of stay. I have a patient that I saw this morning that, we can easily switch them to pills, and we switch them to pills, and I tell them, because they ask me, how long am I going to be in the hospital? And I'll say, you're not going to get held up from an ID standpoint, from an antibiotic standpoint, because we can switch you to pills, and whether you get your pills at home or whether you get them in the hospital, from my standpoint, the most important thing is that you're getting them. Patient-reported complications related to peripherally inserted central catheters. So this is something that, when it comes to PICC lines, avoid putting in a PICC line can actually save a lot of money for the hospital and save a lot of headache for the patient. A lot of patients have complications or adverse issues from PICC lines that they may not even tell people about, like just the bothersome. It's painful. It may be uncomfortable. Usually, people complain more of the tape than actually the line. There's a question: do you use Keflex for that's cephalexin for bacteremia or bone infection? Do you use 1 gram Q6 or Q8, or does it matter? That's a good question. So um, I give it 3 times a day, Q8. And then as far as how much I give, it's kind of dependent. I don't have any hard rules that I follow, but if the patient is obese or very large, then I'll give 1 gram Q8, or if they're very large, I'll give 1 gram Q6. Um, but generally, I try not to give it Q6. I try to give it Q8. If they're not very large, I'll give it 500 Q8, and if they're really large, I'll give it 1 gram Q8. Um, Now, some facilities, they'll have this. I was looking online and I found an example to show. This is IV to PO conversion of antimicrobials, and it talks about the benefits, and then it says a policy statement: all staff must comply. So this is for all of the sites for this this medical facility, and it says all patients initiated on IV antimicrobials will be assessed for conversion to PO, and it'll be PO when possible. So I just wanted to show this because some places they'll make a change like this for all patients whenever possible. IV to PO conversion regimen recommendations. And so this is not mine. This is an example I found where it would be something that hospital policy is to change people, which saves um, um, a lot of aggravation from the patients. It saves money as well, but it's um, if it were me, I'd want a pill if possible. And you can see, um, changing someone from clindamycin IV to PO, and sometimes in the example of Bactrim, sometimes changing them will also reduce the fluid load that you're giving them, because if your Bactrim can also be given in a lot of fluids, but if you're giving them a pill, then you're avoiding all the fluids and excess fluids that you would need to give if you're giving an IV. So oral is a new IV, challenging decades of blood and bone infection dogma. This is where they were looking at invasive bacterial infections, osteomyelitis, infective endocarditis, and they were doing a review to see, is one better than the other? And they were reviewing these studies, and essentially it was just as good. There was no benefit from giving it the whole course IV versus in some cases like endocarditis, starting with IV and then converting to pills for the rest of the treatment. So here it was essentially looking to see, is there a benefit of giving it, and there really was no difference. So all 20 published randomized controlled trials comparing oral to intravenous therapy for osteomyelitis, bacteremia, endocarditis demonstrated oral antibiotic therapy was at least as effective as IV. Now I'm mentioning bacteremia here, but personally, I will do pills for a lot of things. I will give IV antibiotics or at least start with IV antibiotics for Staph aureus. For Staph aureus, I want to make sure that I give longer courses of IV, and sometimes, if I'm planning on giving 4 weeks of antibiotics for, let's say, a complicated bacteremia with MRSA or MSSA, sometimes what I'll do is I'll put in a midline and I'll do 2 weeks of IV, and then I'll switch them to 2 weeks of pills. And that way I can be, sure that they were getting it, that they were taking it, and they got a good amount to start, and then they completed the treatment with pills. So there were studies. There were studies looking at what ID doctors do, and that's what a lot of ID doctors will. Let's see. Sorry, I'm just checking something. A lot of ID doctors take Staph aureus very seriously and make sure that they treat it very aggressively, more aggressively than, say, an E. coli bacteremia or Klebsiella bacteremia that will die more quickly and won't stick places like bones, bone and joints, endocarditis and things as much as Staph aureus would do. And there's actually a lot of evidence that um, for osteomyelitis that pills work very well. And there's, I think there's more evidence for pills than actually IV antibiotics. And the reason is because they will do a study comparing pills to IV, and they'll say, "Oh wow, pills were just as good." And then people will say, "How could that be?" And then they do another study and another study and another study, and then they kind of get this mountain of evidence showing that pills are actually very effective and work very well. So there's a lot of evidence for pills for osteomyelitis. One of the challenges with osteomyelitis was what I was saying earlier about the blood flow. So when you make recommendations for the antibiotic and the dose and duration and everything, you're doing it for a bone infection, but there are so many different bones in the body and some bones have better blood flow than others. So it's hard to make a recommendation and say one thing for all of the bones in the body when it's really dependent on the blood flow for that particular bone with the infection. So here's oral versus IV antibiotics for this is a complicated urinary tract infection. And then you can see, the antibiotic regimens that were used and then the success. So, it says oral versus IV, 100% versus 88%. This was done in, oh, it has the year, 1986. Okay. And then 89, 91, 99. I mean, I think urinary tract infections, I think people are more confident for urinary tract infections than for other things. Um, and if you're wondering, about the antibiotic and does it get into the urine in good concentrations, you can look at the, on Sanford Guide or the how is the antibiotic cleared from the body? Is it cleared through the urine? Well, then, like beta-lactams, you're going to get very high, good concentrations in the urine. Oral versus IV antibiotics for intra-abdominal infections. So the year it was done, Cipro versus ceftriaxone, 96% success versus 93. And then it'll have the reference for each of the studies so you can see, well, what was the difference from, or do they know? Oral versus IV antibiotics for osteomyelitis. So you can see all these, there are a number of different studies and how well did it work. And overall, it looks like 9 randomized controlled trials, over 1,381 patients, 84% versus 83%. So it's very, very similar. And then as far as the shorter is better, this is the screenshot from the website where I was discussing like the study, the type of infection, and then so it's the type of infection, short duration versus long, and then the result, and the number of randomized controlled trials. And then below it, it has all of the studies that are referenced here, so you can look them up and uh, look into more detail if you're interested in that. So, this was, um, oh, so there's a question. What is your favorite PO antibiotic for MSSA bacteremia? In POET trial, they combined amoxicillin or linezolid or dicloxacillin with rifampin. What are your thoughts on this? Yeah, um, so the best drug for MSSA, bacteremia. So the best drug in general, when you're choosing an antibiotic, you want to choose a beta-lactam. So traditionally, it was thought that that cephalosporins aren't as good. Was the original, kind of the dogma of the past, where they would say, um, uh, you needed something, oxacillin. Um, they would say oxacillin is better than cephalosporins, but or nafcillin or oxacillin better than cephalosporins. But when they looked at the studies, they found that the outcomes of um, oxacillin or nafcillin, the outcomes of oxacillin, nafcillin versus cefazolin were the same if the patients are able to complete the antibiotic, meaning if they don't have a problem like a reaction and they're able to complete it, then the outcomes are the same. But the problem with it was that more people had reactions and had, whether it's an allergy or an issue, like a issue with kidney function, um, or neutropenia, more people had issues with oxacillin or nafcillin than the cephalosporin. So they're able to better tolerate the cephalosporin. So then the cephalosporin is actually the drug of choice. So cefazolin would be the drug of choice for MSSA bacteremia. Because if you can't tolerate nafcillin or oxacillin, people don't change to cefazolin, they'll change to vancomycin. And vancomycin is a worse choice Vancomycin there uh, is not as good. The mortality and morbidity is worse with vancomycin than with a beta-lactam. So, if a person has MSSA bacteremia and they're on vancomycin, it'd be important to switch to a beta-lactam. And people will say, "Oh, the vancomycin covers it." Covers it, but it's more likely to die if you're on vancomycin than if you're on a beta-lactam. So, when it comes to MSSA bacteremia, cefazolin it would be the drug of choice. So I would keep them on cefazolin, and I generally, for Staph aureus, will keep them on IV antibiotics for 2 weeks. If I wanted to treat longer duration, I'll do IV, like cefazolin, for 2 weeks, and then I'll change to Keflex for the remaining 2 weeks. Keflex being either 500 Q8 or 1 gram Q8. Yeah. Linezolid would be my next choice. So if I can't give a beta-lactam for whatever reason, if I can't give cefazolin, or sorry, if I can't give Keflex and I want to give pills, if I can't give Keflex, linezolid would be very good. And linezolid has 100% bioavailability. It gets in very well. It works very well. I generally don't like giving linezolid longer than about 10 to 14 days. The issues that you see with linezolid, like pancytopenia, take some time for it to cause a problem. Like, usually don't happen if it's given less than 10 to 14 days. So for that reason, I won't give linezolid, or I try not to give linezolid for things like osteomyelitis, because long durations of linezolid are when people start to run into problems with it. These are great questions, and I hope I'm giving helpful answers. Okay. Any other questions at all? All right. Well, I hope you found this helpful. And if you do think of any questions, you can always send me a message, and ask any questions that you have, and I'll tell you what I like to do, and some of my partners like to do, and how we treat things. But you know, otherwise, if you have any questions at all about specific patients or anything like that, please give us a call, and we're available anytime to help with anything we can. Thank you very much, everybody. Have a great day.